Dear colleagues, ladies and gentlemen, welcome to the view from the Thoraxcenter for Radcliffe Cardiology. My name is Nicolas from Mieghem and I'm standing here with Joost Daemen in San Francisco at TCT 2023. We are reviewing the late-breaking trials and I think we can start with the Partner 3 5-year outcome data.
Yes.
There was a lot of buzz running into TCT for this trial, and I must say at 5 years, no difference between the two treatment strategies, and that was reassuring, obviously, for the TAVR space. And at the same time, there were some kind of indications that were of interest. For instance, there was no difference in hemodynamic valve performance between the two strategies. Even more so, there was 1 millimeter of mercury more transvalvular gradient in the TAVR arm versus surgery, but clinically insignificant. There was also somewhat more valve thrombosis with TAVR, but at the end of the day, no difference in clinical outcome. And also, if you look at the 5-year mortality rate, only 10% in a patient population with a mean age of 75 years at study entry, those are kind of very good results.
Absolutely. Yeah, I think very reassuring results. A lot of fuss about potentially crossing event curves with mortality, but at the end, really not really convincing data. And also the valve thrombosis rates. I mean, below 2.5% is, I think, still very low, up to 5 years. So to me, reassuring results.
And also, it did not result in more bioprosthetic valve failure. So that is definitely, from a clinical point of view, very relevant.
Correct.
Well, then in the following up the Partner 3, there was also the 4-year data from the EVOLUT low risk. Mike Reardon presented that data, and those data looked really excellent. As you know, mean age of these patients were again 74 years old. The mean gradient of the valve procedure was only 4 millimeters of mercury with TAVI versus 9 versus surgery. So there, the hemodynamic valve performance of the supraannular functioning valve, as we know, was superior, and it turned out to be superior at 4 years. There was more endocarditis in the surgical arm versus the TAVR arm, and that was notable, 2.2% versus 1%. But if you then look at the primary composite, and that was the main takeaway, at least as far as I'm concerned, it was definitely in favor of TAVI because there was a significant difference in favor of TAVI. 14% for surgery versus 10% in the TAVI arm. If you focus at mortality, it was 9% versus 12%. That slightly missed statistical significance with a p-value of 0.07. And if you look at re-interventions, also very low numbers in both treatment arms. 9 cases with TAVR, 10 cases with surgery. No differences in rehospitalization. So overall, very strong data for TAVI. In my opinion.
I totally agree, and even for this particular data on EVOLUT, you saw the event curves even disseminating or diverging over time in favor of TAVI. So also with respect to the mortality, there will be longer term follow-up. So that is definitely something to keep following in the future.
Yeah, but you know, if you can't help but comparing the two trials, right? And if you look at the Partner 3, you do see the curves like coming together at 5 years, which is okay because you see that the hard clinical endpoints are very low, but in the EVOLUT low risk arm, you see that the two curves are diverging further, and as to your point, so that is quite notable. And the question then is this a device effect? Well, we probably will need more data, we need more follow-up, more trials, but I think this is an indication that this is potentially a device effect.
JenaValve.
Yes, JenaValve, that's a totally different concept, and it's focusing on aortic regurgitation. So the Trilogy valve was being studied in the ALIGN-AR trial. 180 patients were treated with pure AR in the United States. Approximately 50% of the patients were women. The STS score was 4%. And there were, if you look at it from a procedural point of view, we were interested in embolizations. Well, the embolizations were not really an issue. In these patients with no aortic root calcification, only 4 embolizations. And that is quite powerful because we are all familiar with these other devices, these other TAVR devices that are designed for degenerative calcific aortic stenosis. Well, you do see all kinds of issues with valve migration, valve embolization, not so with the Trilogy valve. Mortality at 30 days, only 2%, stroke, only 2%, moderate PVL, only in one patient, 0.6%. So very powerful data. The only thing that was notable was the pacemaker rate. And as expected, we already mentioned that in our preview, 1 in 4 of the patients ended up with a pacemaker. At the end of the trial, there was this trend towards decline, so fewer patients were requiring a pacemaker. But still, I think AR is a different animal than aortic stenosis. Probably also the way the conduction system is being affected by the AR upfront might then have consequences for the TAVR procedure. So I'm not very concerned about that. Don't forget, these are potentially very vulnerable patients, and surgeons are not very keen on treating these patients.
Yeah, also to me, very reassuring findings in a technology purely developed for AR initially, and in a subset of patients that was initially actually declined for surgery.
Yeah.
Pacemakers from 30% in the beginning to 14% at the later stages within the trial, with a little bit of less aggressive oversizing, maybe somewhat higher implants. So also that, I think, reassuring, and definitely something that will be continued in the future with larger trial programs in different sets of patients.
For sure. Next up, VIVA. VIVA was an important trial, I think. It was comparing TAVI with surgery in patients with a small anatomy. And as expected, we had the majority of patients were women, almost, so more than 90%. 150 patients were included. STS score was 2.5%. So we're talking about a low-risk population. In the TAVI arm, both self-expanding and balloon expandable valves were used, 60% self-expanding, 40% balloon expandable valves. And then in the surgical arm, very noticeable, only 7% of the patients received aortic root enlargement. That said, no difference in hemodynamic valve performance between the two treatment strategies. And at 30 days, there was only 1 death in each treatment arm. There was no stroke in the TAVI arm, 2 stroke cases in the surgical arm. So overall, very good results, and out to 2 years, no difference between the two strategies in terms of clinical endpoints.
Would you have expected better gradients in the TAVR arm? I mean, it was 50% EVOLUT, 50% SAPIEN in this trial, more or less.
Well, so that obscures things, obviously. If you then look at the TAVI arm in general, I don't know the granularity, whether they separated, but separated between balloon expandable and self-expanding valves. But obviously, the numbers will be very low
it's
for
a relatively small trial.
But I was. To be honest, I was expecting larger valve areas with surgery, and I was expecting more root enlargements.
That is correct.
And I think because of the low rate of root enlargements, there was no difference in hemodynamic valve performance. So yeah, but again, a good study by Jules Cabot, and definitely something that we can consider in our practice. So also in low-risk patients, TAVI is a good alternative to surgery in small anatomies. Okay, let's move to a different area. The AGENT trial.
AGENT, so in the coronary space, the AGENT trial to me was one of the most interesting studies to be presented this meeting. So please recall, AGENT was the first FDA, actually Boston's pivotal trial on getting the AGENT paclitaxel-coated, drug-coated balloon tested. And this could be, with this trial, the first device being admitted to the US market. So from that perspective, a very important trial. So it was a trial that aimed to enroll 480 patients with in-stent restenosis to either the paclitaxel-coated AGENT balloon or standard balloon angioplasty. So no stenting, just plain balloon angioplasty. Very interesting. This trial aimed for a event reduction of around 50%, which was very ambitious in its primary endpoint, being target lesion failure at 1 year. But then it appeared that this trial enrolled so quickly that the 480 patients were enrolled very swiftly. A lot of discussions with the FDA, because most patients even didn't manage to get that 1-year follow-up. And then the FDA agreed to present an interim analysis, which this presentation concerned, on the 40% of patients that, on the at least data, with 40% of the patients having a 1-year follow-up. And with that, they were able to demonstrate a significant 10% absolute difference in the primary endpoint, 18% in the target lesion failure in the paclitaxel-coated balloon arm versus 28 in the control arm, and with that a remarkable difference in the primary endpoint, driven by a 50% reduction in TLR, as you would have hoped for, but also a 50% reduction in the risk of repeat target vessel myocardial infarction, which really exceeded my expectations, I have to admit. The data will be continue to be completed, so we hope that the final publication will contain the estimated number of 600 patients that will be enrolled. So with that, the final results may change a little bit, but with these findings, I think a very positive trial, and I think a step in the right direction for getting this device approved on the US market, specifically for in-stent restenosis in a subset of patients, which I forgot to mention, which was quite complex: 50% diabetes, 43% with multiple stent layers. So really patients in which you would also perhaps not have been so keen to put additional stents. So that to me takes also away one of the perhaps key limitations of the trial in terms of design.
It's good to see that we have a positive study with drug-coated balloons for this indication. At the same time, do you have some more insights in the control arm? What kind of balloons were being used? Were non-compliant balloons, cutting balloons?
No, non-compliant balloons. I haven't seen any data on the use of cutting balloons. It's an interesting point, by the way, because a lot of new hypotheses are being raised to first do a cutting or scoring balloon before applying the drug-coated balloon in order to get a bit better drug dissemination. But I think this is a concept that needs to be tested into greater detail.
And imaging?
Imaging, yes, good point. Imaging was used, I think it's 75% of the patients within the trial, which is remarkable for a trial like this. But it does a little bit to the guidelines that are really pointing in a direction to recommending the use of imaging specifically in cases of
and I think it makes sense, right? You want to understand what's going on, what's happening, what kind of restenosis are you talking about, and that might also help determine your strategy. And in terms of using a non-compliant balloon prior to a drug-coated balloon, I must say I do that quite often.
Yeah, but I think that's also what is routinely recommended to be done.
Okay, all right.
More on DCBs was the DCB-ACS trial, which was the Chinese trial from Harbin, randomizing 224 patients presenting with STEMI that underwent successful recanalization of the culprit artery, which then should contain a lesion of less than 28 millimeter, to either drug-coated balloons versus standard of care, which typically included a drug-eluting stent. But then interesting, a primary endpoint of FFR at 9 months. I anticipated actually a negative trial, since I assumed that the acute gain with a stent would obviously significantly larger than with the drug-coated balloon. But that said, the FFR at 9 months, 0.89 in the drug-coated balloon arm versus 0.9 in the isotermal stent arm, which was obviously meeting the criteria for non-inferiority. And with that the trial met its primary endpoint. Obviously, small number of patients, so no significant differences in the primary endpoint at 1 year. But what you did see is a slight divergence of the event curves, even in favor of DCB arm at 1 year. So obviously very provocative, low number of patients. I don't think we should pay too much attention to that. But at least the trial adds a little bit of conceptual proof on the potential feasibility of this strategy in patients with ACS. That said, I have to admit I didn't see any data on the rate of bailout stenting. I think this is an important confounder in trials like this. In the PAPA trial 10 years ago, almost 40% bailout stenting in the DCB arm. So this is something I think that should be taken into account. I haven't seen the details for this trial.
Well, but rest assured, we will see many more drug-coated balloon trials in the near future. And of note, in Europe, the uptake of drug-coated balloon is quite minimal, right?
It's still low. I think it's increasing for in-stent restenosis. There's a lot of focus now on small vessels, but I mean, according to the trials ongoing, small vessels are now even accruing to 3.5%. I'm not sure that's the direction to move on to, but I think these data are interesting.
Very good.
TPAS, platelets. So this is the large randomized control trial from South Korea comparing a shortened or abbreviated DAPT regimen of aspirin and ticagrelor versus a standard DAPT regimen of aspirin and ticagrelor in patients presenting with acute coronary syndrome. So a total of 2,850 patients were randomized either to a regimen in which the aspirin was stopped, in this trial on a median of 16 days, and then pursued with ticagrelor monotherapy for up to 1 year, versus a standard control arm of DAPT for 1 year consisting of aspirin and ticagrelor. The trial was designed in a non-inferiority way. We expected the trial to meet that endpoint following the TICO trial, the Twilight trial, the sub-analysis of global leaders. But these data were even perhaps a bit more striking. So finally, a primary endpoint, a net adverse event clinical endpoint, including ischemic as well as bleeding events, of, if I'm correct, 2.8% in the abbreviated DAPT arm versus 5.4% in the control arm. Well, that the trial not only met a non-inferiority, but even superiority. And that was to me quite striking, in a difference that was obviously, as expected, driven by a significant reduction in major bleeding, which was 1.2% in the abbreviated arm versus 3.4% in the control arm. So with that, this is now the third trial in line, also now in a Asian population, demonstrating the concept of a abbreviated DAP regimen in patients with ACS. So this is, I think, a series of trials now that may have the potential to change the guidelines into simplified DAPT or simplified platelet aggregation regimens in patients with ACS.
And no signal of stent thrombosis?
No, stent thrombosis rates were very low. I don't have the exact numbers here, but the results were very, very promising. And mind you, I mean, 2 to 5% event rates, net adverse event rates at 1 year is by itself already extremely low, which is typical for these Asian trials, which tend to have somewhat lower event rates as compared to the Western trials we have been looking into.
So they beg for trials also in Europe and in the United States.
I think with Twilight and TICO and also the global leaders data, I think there is now a significant body of evidence supporting the safety and feasibility of this concept.
Yeah, I agree. Watchtower. Yeah, Watchtower, we go back to the structural space. Watchtower was an interesting study comparing the introduction of a Watchman LAA closure in patients who undergo TAVR and have atrial fibrillation. So patients were randomized to either TAVI plus a Watchman LAA closure or TAVR plus standard of care, including oral anticoagulant drug therapy. 349 patients were enrolled. It was 80 years was the mean age, 40% were women. General anesthesia was applied in 84% of the patients in the Watchman arm versus 36% in the control arm, and also the implementation of Watchman use added 43 minutes to the procedure. Okay, there was no issue of harm, if you will. There were only 4 pericardial effusions with the Watchman versus 1 pericardial effusion in the control arm. And if you look at the antithrombotic regime that was applied in the treatment arm, so patients received the Watchman and then continued with vitamin K plus clopidogrel for 6 weeks, and then DAPT, aspirin and clopidogrel for 6 months, and then basically the antithrombotics could be stopped. Well, there was no difference in the primary endpoint of death, stroke, and major bleeding, which is an important net adverse event composite, if you want, at 2 years of 37% versus 34%. So the non-inferiority was met. There were the stroke rate was 7% in the control arm versus 5.7% in the Watchman arm. And there was also no difference in bleeding. So I think interesting data. We already discussed in our preview whether this will lead to an increased uptake of Watchmans, for instance, in the Netherlands. No, because there is no reimbursement for Watchman. So I think we need to fine-tune a bit more which patients would benefit from LAA closure. But again, I think interesting findings, so definitely no signal of harm. And also notable was that 1/3 of the patients in the control arm were no longer on oral anticoagulant drug therapy at 2 years. So they had suboptimal stroke prevention at that point. So this is of interest in elderly patients, obviously.
Conceptually, absolutely, I think a interesting technology, but we definitely need more data to get this implemented into our practice.
For sure.
Triluminate.
Yeah, so we move now to the tricuspid space. There were two trials that we wanted to highlight. First, there was the Triluminate pivotal trial. That was already presented earlier this year, but now we have the full cohort of patients. So 572 patients were treated in the trial, whereas only 350 patients were included in the New England Journal paper of last March. The results were quite striking. So 88% of the patients in the treatment arm, so with a TEER procedure, had a reduction to less than moderate TR, which is quite impressive. And it resulted in an improvement in 6-minute walk test of 15 meters versus a deterioration of the 6-minute walk test of 12 meters in the control arm. So these are minor differences, and the KCCQ increase was 6 KCCQ points in the control arm versus 14 in the treatment arm. So yes, I think what we can conclude from this trial is that TEER does work with a TriClip. You will reduce your TR in selected patients, obviously, and it will translate in better overall functional performance of these patients. So I do feel that this is a right step or a step in the right direction.
I agree. I think promising data, differences are small. 16 meters is not a lot. No. But I think you also need to be honest and put that in perspective to the type of patients that receive these procedures, right? These were not 60-year-old vital walking patients. No, these were elderly, typically frail, in which you would not expect for them now to run for 2 kilometers in 6 meters, in 6 minutes. So this is, I think, promising data.
Yeah. And then there was TriScent-2. And TriScent-2, different concept. We're not talking about TEER, but we are talking about tricuspid valve replacement. And Sushil Kodali presented data on 150 patients of the randomized control trial. So the randomized control trial was randomizing 400 patients, 2-to-1, to either tricuspid valve replacement with the EVOQUE system versus the control arm of optimal medical therapy. 96 patients received EVOQUE transcatheter therapy. 54% were in the control arm. The mean age of the patients was 79 years. 80% were women. And the STS score was 10, so a very high risk patient population. AF was approximately in all patients, atrial fibrillation. And also of interest, 40% of the patients had a pacemaker in place. So regardless of that, it was predominantly secondary TR. The procedure time was less than 2 hours, which is quite good for this kind of technology, in my opinion. Only 2% of the patients required a conversion to surgery. So it seemed to be a procedure that has acceptable safety. And the major adverse event rate was lower in the treatment arm. So 27 versus 37%, with a mortality rate of only 3% at 30 days and a pacemaker rate of 14%, with major vascular complications of only 3%. Only 5% had more than mild TR after an EVOQUE implantation. And all that resulted in also an improvement of functional status. So the KCCQ improved with 21 percentage points. That is a lot.
That's a lot.
Yes, versus only 3 points in the control arm. And the 6-minute walk test improved marginally with 10 meters and deteriorated in the control arm with 20 meters. So I think these are good results, and these definitely are supporting transcatheter treatment of tricuspid regurgitation.
Yeah, totally agree, and in line with the previous results, I think a right step forward in treatment of patients with TR.
Yeah. So we go back now to STEMI patients.
STEMI patients, PICSO. So PICSO, please recall, PICSO was the system is the pressure-controlled intermittent coronary sinus occlusion device that was developed with the intention to reduce infarct size in patients presenting with myocardial infarction, with obviously the intent to improve prognosis in patients presenting with large infarcts. So this, as predicted in the preview, was the proof of the pudding. So the randomized controlled trial, 145 STEMI patients with large anterior STEMI, so proximal LED occlusions, that were then one-to-one randomized to either primary PCI with the PICSO technology versus primary PCI alone with the primary endpoint of infarct size at 5 days. So a little bit as anticipated, difficult trial, yet still 75 to 80% of patients met the primary endpoint of reaching the MRI. This is always a bit complex. We learned that from previous trials, but that's still a representative sample of patients, but then no difference at all in infarct size. 27% in the PICSO arm versus 28% in the control arm, obviously not statistically significantly different. The procedure appeared to be safe, but was associated with 45 minutes more procedure time, more radiation, more contrast load. So with that, I think a little bit disappointing results for this technology, at least conceptually. Also in terms of clinical endpoints, small sample size, but in all these secondary endpoints, including clinical endpoints, MR parameters at 5 days, but also at I think 6 months, not even a trend towards a treatment effect with this technology. So a little bit disappointing.
Well, and it illustrates how difficult it is to improve further on the concept of primary PCI.
Yeah.
And we'll see what other trials, for instance, the STEMI DTU. Will offer, right? This is a different concept where, the impella unloading is implemented before revascularizing the occluded vessel. These concepts, it's not a given,
No, it's as you say, it's difficult, and I think, and I haven't seen that for PICSO, I have to admit, but what could be one of the triggers of effect, irrespective of the type of technology you use, is the ischemia time. Mm-hmm. And I could envisage that the longer you wait or the slower you are with implementing these new technologies, the smaller the actual treatment benefit will be. And in that perspective, I see light at the end of the tunnel, but there needs to be better technologies and more proof of the concept. Finally,
we cannot stop without renal denervation. So what's happening here?
Yeah, so Ajay Kirtani presented the pooled analysis of the RADIANCE trial. So please remember the three randomized control, sham control trials comparing ultrasound RDN with the Paradise system versus sham in patients either with mild to moderate hypertension or therapy-resistant hypertension in the RADIANCE TRIO program. And we followed these patients for a primary endpoint at 2 months, all positive in each of the 3 individual trials that were pooled. So a total of 506 patients that were now followed up until 6 months. And please remind you, all these endpoints were blinded to patient and physician. But after 2 months, after the primary endpoint, a stepwise protocolized antihypertensive drug therapy increase was allowed, titration, I should say, was allowed up to 6 months in order to assess the long-term effect of the treatment in patients with hypertension. Very reassuring findings. So the therapy at 6 months appeared to be very safe with no differences in the major adverse event rates between both arms. But importantly, what we found was that in patients in the RDN arm, significantly less drugs were added between 2 and 6 months, on average 1.2 versus 1.7 in the control arm, but still less. So you would expect that would dilute a little bit the treatment effect, and that was indeed the case. Now at 6 months, in which adherence, by the way, was still 80% by metabolite testing, so very good. Still a statistically significant difference in blood pressure in favor of the RDN arm as compared to control of 3 millimeters of mercury based on daytime ambulatory blood pressure was the primary endpoint, and between 5 and 6 millimeter reduction in the office and home blood pressure measurements, which is relatively small, but should be seen in light of the fact that patients in the control arm received more drugs during this titration period of 2 to 6 months. So to me, reassuring data, actually further confirming the efficacy of the therapy at least up to 6 months, and another step forward in the way towards FDA approval that is expected to be granted within the next couple of weeks for this technology.
And so what do you think is going to happen in the future? What kind of studies are going to come in the space of renal denervation for hypertension?
That's the $1 million question. There's a lot of debate now as to which type of patients this technology should be applied, and people say, yeah, this should be restricted to patients with very difficult to control hypertension. Conversely, the vast majority of patients we see are obviously those who are not willing to take drugs, who are intolerant to drugs, or who cannot be controlled with the current means and measures for getting blood pressure control. So it's a huge number of patients, and whether you should restrict this to high-risk patients, low-risk patients, resistant patients, that's I think a discussion that has not been settled. Will also be driven by cost effectiveness models that will need to be performed. But in my perspective, and that's a discussion we had with both companies for quite some time, a outcome trial is to me is inevitable. These are specifically, if you focus on high-risk patients with high risk for stroke, high risk for repeat hospitalizations, for hypertensive crises, etc. So this not necessarily would need 15,000 patients. I think in an era in which reimbursement is now slowly being managed and established in even European countries, I do believe a outcome trial would be a step forward to finally convince the community of the potential therapeutic effect of the therapy.
All right. With that, good. I think we wrap up the late-breaking trials here at TCT. Thank you very much, Joost. I also want to thank Radcliffe Cardiology and CRF for the ability to do the recordings here on site. It's always a pleasure to do that. I'm also about to lose my voice because this was a quite intensive stay here in San Francisco. Thank you very much for joining us for this wrap-up, and we'll see you for the next preview of AHA.
Thank you for watching. Bye-bye.
Bye.